دكتور محمد معانا. دكتور
السلام
محمد
عليكم، سامعني ناصر؟
سامعك.
الله يعطيك العافية يا رب.
فيك أخبار.
تمام الحمد لله.
طيب، بلش نعمل شير للصفحة.
صوتي واضح يا ناصر؟ بس على الصوت.
واضح الصوت.
خلاص اوكي.
طيب، خير جميعا، الله يعطيكم العافية. آه، راح جد ترحيبنا في لقائنا الأسبوعي المتواصل في أنشطة علمية ومحاضرة أسبوعية. محاضرتنا لهذا الأسبوع بعنوان Distal Structures Updates مع الدكتور حمد السعيد.
ناصر
دكتور
بس
ناصر سيدي دكتور ناصر سيدي، صوتك مش واضح. صوتك مو واضح سيدي.
نعيد الأول.
كان بعيد بعيد شوية، هيك أحسن.
طيب، مساء
هيك
الخير جميعا، الله يعطيكم العافية. واضح هيك الصوت؟
ممتاز سيدي، ممتاز سيدي.
أرحب فيكم في لقائنا الأسبوعي المتجدد ومحاضرتنا هذا الأسبوع بعنوان Distal Radius Structure Update مع الدكتور محمد السعيد، سينيور سبيشالست في Advanced Trauma Team مركز تأهيل الملكي. دكتور محمد، الله يعطيك العافية.
الله يعافيك يا ناصر.
تفضل دكتور محمد، معك المايك.
طيب بسم الله الرحمن الرحيم، السلام عليكم. الله يعطيكم العافية جميعا. إن شاء الله ما راح أطول عليكم. راح يكون يعني our topic today would be about the structures, which is a very common injury that presents to the A&E, and you must have faced that times and times while you are being in the A&E. If we start with this, بدنا واحد من الريزدنتس، يعني سنة رابعة أو خامسة لو سمحتوا. Any candidate، أي واحد. يلا يا شباب.
يعطيك العافية سيدي.
خير.
أهلا، مين؟
محمد البكري، سنة رابعة.
أهلا يا محمد. So Muhammad, if I give you this X-ray and I'll tell you that this is a 30 years old male patient had a fall from standing position, what other things you want to know about this and what is your provisional plan?
هسا أول شيء بهمنا الهيستوري تاع المريض. نبدأ بالهيستوري
Okay.
والفيزيكال اكزامينيشن. بهمني هل هو رايت هاند دومينانت ولا ليفت هاند دومينانت. هيز
Okay. هو
فيزيكال.
هو left hand dominant و this is a
شو الليفل
left
اوف
hand.
اكتيفيتي بتاعته.
ايش هو علي صوت لو سمحت.
ليفل اوف اكتيفيتي الاوكيبيشن تاع المريض كمان.
Is a very active young 30 years old.
تمام، بنروح الفيزيكال اكزامينيشن نشوف هل هي كلوزد انجري ولا اوبن انجري.
This is a closed injury with intact neurovascular examination.
تمام.
Anything else you want to know?
آه، بالاكزامينيشن لوك في الموف وال تندون اذا في تندون انجري رابتشر مرات معها.
So basically, as
بالهيستوري
initial
وبالفيزيكال.
history, this is fine. So if I ask you, what is your initial thought about the treatment of this? Would you treat this conservatively, surgically, or you need another step to decide?
So we need more further images for this patient,
Okay.
like CT scan, since it's distal radius, نشوف interarticular extension and pre-op planning.
Okay. So you have decided that this is a surgical case or not?
I would
بدنا
go with
سيدي بعدين
surgical
نقرر.
treatment for this patient, since this patient is young, active male patient. Uh, so I would give him the best treatment option. بس بالأول طبعا نعمل له reduction قبل.
Okay, that's fine. So you
نعمل
want
له
to see a
reduction بعدين
reduction.
بصور CT طبعا.
So this is the reduction. What do you say now?
عشان أشوف. بس نشوف نحسب في بارامترز نحسبها radial inclination radial radial height نشوف ال شو
Okay,
اسمه.
now if you talk in general, just have a look at this. Would you like to have a further step or further imaging, or you can decide on this?
I would go for CT. تمام شوف إذا في
ICT.
articular
This
step
is the
up
3D CT. On your left hand is the dorsal, and on your right hand is the volar aspect.
volar. Okay.
Have this changed your mind or not?
Yes. في عندي ال critical corner piece is injured.
Okay.
So I need to address this fracture because
So what
it's
is your
unstable
final plan,
fracture.
or
It's gonna go
what is your
volar.
provisional plan regarding this patient?
Op reduction, internal fixation for this patient.
Okay.
First of all, I would go with volar plate.
Okay, that's fine. Okay, thank you. Another candidate, Shabab. بدنا رحمن كمان candidate لو سمحت. عادي مش شرط ثالثة رابعة. Anyone who can vote or who can يعني volunteer to answer. Feel free.
نعم سيدي.
مين لطفا؟
محمد الفوعير سيدي، سنة ثانية.
أهلا يا محمد. So
هلا
I can
سيدي.
give you this X-ray and I'll tell you that this is 70 years female, had a fall from standing position, and this is her non-dominant hand. Okay, what is your initial thought about this fracture? Would you like to know anything else about this? And what is your provisional plan of management?
سيدي هسا أول شيء زي ما حكى دكتور محمد البكري، يعني أول شيء بيهمني الهيستوري والفيزيكال اكزامينيشن. بالبداية الهيستوري بيهمني إنه هي أول شيء عمرها 70 سنة، فهي كبيرة بالعمر. ثاني شيء بيهمني إنه هي النت دوميننت هاند،
Okay,
فممكن إنه أعمل لها ريدكشن، وأفتر ريدكشن ممكن إنه أقرر تو جو فور كونزرفاتيف تريتمنت يعني.
so your provisional plan is conservative, right?
مهم.
So this is the post reduction. Have you changed your mind or you have the same plan yet?
يعني سيم بلان سيدي.
Okay, thank you.
هذا سيدي.
ماشي يا شباب. So as we said, we are going to review the distal radius fractures. Actually, this is the most common fracture presenting to the knee, and especially in the elderly, it is the second most common fracture after hip fractures. And it is fairly common in middle age and in the elderly, and especially in females, with a ratio of around 2 to 3 to 1, especially after the age of 50. So if a patient presents with distal radius fracture, especially in the middle age or in the first thing that should come to your mind is the risk of osteoporosis. And this fracture itself, it might be the first fracture or the sentinel fracture, indicating that this patient might have osteoporosis. And you, as orthopedic surgeon, you should initiate the cascade of investigation regarding the osteoporosis, since you are the treating surgeon. And a special point about these patients, especially the elderly one, they have impaired postural stability. And these patients who develop distal radius fracture, they are fitter and they have intact reflexes. So once this patient falls on his right side or left side, he stretches his hand to not to injure his hip or his body. So while other patients who are more elderly than them, they fall directly on their hips or on their shoulders, developing neck-of-femur fractures or proximal humerus fractures. The mechanism of injury in more than 90% of the cases, it is a fall from a standing position on an outstretched hand. And usually, most it is dorsally angulated because we fall on the outstretched hand in wrist extension. And usually, fractures happen in degrees between 40 and 90. And if the patient falls on the flexed wrist, he or she will develop volar shear fractures, as we will come later. Other mechanisms like fork height, RTAs, industrial injuries constitute a minor percent of the whole mechanism. And when you talk about the distal radius fractures, it is a complex injury really, involving the distal radius itself, the intercarpal injury, intercarpal ligaments, and the distal radioulnar joint. So one of the common associated injuries is the interosseous ligament injuries, mainly the scapholunate and lunar triquetral. It's in almost around 20 to 30% of cases. And the problem in these injuries that is difficult to diagnose in the setting of distal fractures because the whole area will have flowing, so will have fluid. So even if you do an MRI, it would be difficult to assess the integrity of these ligaments unless there is a frank separation between the scaphoid and lunate or the lunate and tricutrum. And still, the management of these injuries remains controversial and is left to the surgeon preference. وبهاي المحاضرة احنا عن كل نقطة بنحكيها كونه العنوان تبعها ابديت رح نحكي الابديت عن كل شيء بنمر عليه. So management of the interosseous ligament injury distal fracture, there is no clear-cut guidelines to guide us to treat this, and it's left to the surgeon. The most common associated injury is the TFCC injury. Is around half of or more than half of the cases they will have a TFCC injury in the form of peripheral avulsions, and X-rays you can see it as a form of ulnar styloid avulsion, and most cases are treated conservatively. Other injuries like the chondral injuries, as any other distal bone injury, it might be intra-articular causing chondral injury, and this is the likely cause of developing post-traumatic arthritis and stiffness. And 1/3 of cases is associated with chondral injuries. Other injuries like the scaphoid and or other carpal fractures, in these fractures, they are treated as if there is no distal radius fracture. So if a patient has distal radius and the scaphoid, you treat the scaphoid if it is indicated as if there is no distal radius fractures. The alarming thing or the thing that you should give attention to while you are examining the patient is the presence of acute carpal tunnel syndrome. This is the most urgent injury and must be addressed urgently. So median nerve contusions are also frequent and can be monitored for resolution. Now, the difference between acute carpal tunnel syndrome and direct nerve contusions is the time, the progress over time. Now, for patients who present with median nerve contusion, they present with paresthesia and numbness that are stable, that doesn't progress. While in patients with acute carpal tunnel syndrome, they start with mild form of paresthesia and numbness, and they progress over time. And these patients who should you pay attention for, and you treat them urgently by doing carpal tunnel release. And note that even patients with distal radius fracture, if they don't develop acute carpal tunnel syndrome, they are at higher risk of having chronic carpal tunnel syndrome even after 25 years later. If we come to the anatomy of the distal end of the radius, if you look to the left side of your hand, this is the volar aspect or the palmar aspect of the distal radius. And you see that the radial side is higher than the ulnar side. And the most prominent area, you see, this is the watershed and the volar rim. You have to memorize this because we will come to this later. On the dorsal aspect, you can appreciate the presence of Lister tubercle around which the APL tendon runs, and on your left side is the sigmoid notch where the ulnar head articulates. Now, if you look end on to the distal radius, it is composed of two fossa. The radial one is the scaphoid fossa or facet, and the ulnar one is the lunate one that articulates with the ulnar. Especially about this cross section, cadaver cross section, you can notice that the volar rim or the cortical, the lunate critical rim is around 3 millimeters more volar than the radial side, and this makes it prone to have volar shear fractures. Another notable thing is the distal radial ulnar joint, that you can see that the distal radial ulnar joint is a hyaline cartilage joint. And this means that if you have a step or you have a fracture or extending to the distal radial joint, it should be addressed anatomically to improve the function of the distal radius fractures. And as concept, it is looked for as three columns: the radial one, the radial half of the radius, mainly the scaphoid fossa, articulating with the scaphoid, and the middle one or intermediate column, the middle column articulating with the lunate, which is the one that is responsible for transmission of the force or weight from the wrist to the forearm, and the ulnar column, which is the ulna and the TFCC. Now, if you want to evaluate a wrist, whether a trauma or elective basis, you need to know how to do the X-rays first. as you notice here. صراحة أنا قاعد بعمل بالمحاضرة، حاولت أدور على إكس رايز راح تشوفه هسه. it's difficult to find proper X-rays للأسف. It's nice for you, even as a doctor, to know how to do a proper X-ray. If you look to the left side, you will take usually PA, posterior anterior views. The patient should be sitting or kneeling at the level of the table, and the shoulder should be abducted 90 degrees, elbow flexed 90 degrees, and the arm is in midway. It's not supinated, it's not pronated. On the right side itself, the patient should kneel near the table, and if you notice that the forearm is in neutral position, it's not supinated, it's not pronated, because if you do it on either way, supinated or pronated, it might change the parameters. Now, when you have an X-ray, you want to know how to say that this is technically good one. So as exposure, you need to see the metacarpals and the distal third of the forearm. And for the rotation, as we said, you look at the ulnar styloid. It should be on the far ulnar side of the ulna, and adjacent to it is the ECU groove. Another point is if you look to the lunate, it should overlap almost 50% or two-thirds of the lunate should articulate with the distal radius. If you have these parameters, you can say that this is almost a true AP. If we come to the lateral view, we've got two criteria to say that this is a true lateral. The ulnar addresses should be interposed, and this is important to assess the distal radial injury or congruency. The second thing, if you look to this bone, this is the pisiform, and if you look to the anterior aspect of it, this cortex should be midway between the tip of the scaphoid and the anterior cortex of the capitate. If you have these two things, you can say that this is a true lateral breast. Now, if you
والله
come to the
دكتور
X-rays, تفضل، في أحد يحكي؟
دكتور يصير تعيد بس الترو لاترال بعد اذنك سيدي.
that's fine. So واضحة صورة الإكس-رايز؟
واضحه سيدي واضحه.
So البوينتر واضح محل ما بحط أنا.
واضحه سيدي.
Okay. So I'm now drawing or pointing up the pisiform. The anterior cortex of the pisiform should fall between the anterior rim of the scaphoid, high anterior rim, and the anterior cortex of the capitate. It should be in midway on the middle third. This is the best way how to judge that this is a rotated wrist or this is a true lateral wrist. واضح؟ صالح اللي بحكي صح؟
صالح سيدي واضح. الله يعطيك العافيه دكتور.
Okay, thank you. So when you have an X-ray, there are some parameters that you need to measure in order to assess whether this fracture can be treated conservatively or surgically after reduction. The first one we come to is the radial inclination. So we draw a longitudinal line along the shaft of the radius and another 90 degrees line touching the most ulnar part of the distal radius, and another oblique line from the radial styloid to the most ulnar aspect of the radius. And usually it is around 20-30 degrees, and we can accept up to 5 degrees loss. The second parameter is the radial height. The same, you do a midline or intramedullary line or long axis of the radius, and you draw then two lines perpendicular to the first one. The first line is at the level of the distal radius, most ulnar aspect of the distal radius, and the other one at the tip of the radial styloid, and you measure the distance, the vertical distance. It's usually around 30 millimeters, and we'll accept up to 5 millimeters. And you will notice that this is the most important parameter in terms of loss of reduction and the outcome regarding the power grip. The third one is the volar tip. Naturally, there will be around 10 to 11 degrees of volar tip in all radii. So you draw on the lateral side the longitudinal axis of the radius, and you draw two lines, one perpendicular line to the first one from touching the most volar lip, and another oblique line from the volar lip to the dorsal lip. And the angle between them is around 11 to 13 degrees in normal patients, and you can accept up to neutral or 5 degrees of dorsal angulation. And we'll come to that later on. The last thing, or the one before the last, is the ulnar variance. This is a measure of how measure of the relation between the radius and the ulna. It's the only one, and it's the vertical distance between the distal aspect of the distal articular surface of the ulna and the distal aspect of the radius. You draw it by drawing again the longitudinal axis of the radius and another line touching the most ulnar side of distal radius and another line touching the distal aspect of the ulnar head, and you measure the distance between them. It's normally in zero, but are there some variations between +2 and -2? In normal rest, usually most of the load is transmitted through the radius with a ratio of 80% from the radius and 20% from the ulna. This is a normal rest with neutral variance. So if the ulna becomes more prominent or more long, so it will transmit more load to the radius. So let's say لما يكون 2+, which means that the ulna is 2 millimeters higher than the radius, usually 60% or less is transmitted by the ulna and 40% is transmitted by the radius, sorry, and the rest is transmitted by the ulna. When we reviewed the 3D scan of the distal radius, you saw that the most prominent aspect from the more volar aspect is the critical corner or the volar lunate aspect. And when you take an X-ray, this is the distal radius. If you follow the volar cortex, here, there, this is the radial styloid. But you will have a teardrop structure here, and this is a recent, maybe 10 years old parameter that is added. It helps in assessing the reduction of distal radius fractures intraoperatively. We call it the teardrop angle. You draw an axis of the distal radius, and you see the teardrop, which is the volar lunate corner of the distal radius, and you do a bisector line, and the angle is around 70%. Any deviation from this would indicate that there is a malreduction of the articular surface in the distal radius. Again, hyperfracture. If you look here, that this is the volar aspect, but these angles usually are measured post-reduction, so you can't forget about this slide. Now, as the guys in the first of the lecture, they requested a CT better to assess the distal radius, which is fine. So the CT has a role in distal radius fractures for assessment of interarticular extension. Sometimes it's not that evident or clear on X-rays if the fracture is intraarticular or extraarticular. So you can order a CT. You would better assess the step off and the degree of comminution. Another important thing that you might not notice on the X-rays, and most of the cases you can't see on X-rays, is the dye bunch, which is a central depression, whereas the anterior cortex, the posterior cortex, medial lateral cortices are fine. Usually the central depression, we call it the dye punch, and this is best assessed by CT. And the 3D helps you in doing pre-op planning, especially if you want to do fragment-specific fixation in order to address each segment separately. Now we come to the classifications. We, as orthopedic surgeons, we like the classifications in order to guide plan and to communicate with each other. So we have many classifications of the distal radius, but unluckily, none of them has developed a practical value to guide us for treatment. Or most of them become based on radiological appearance of the X-rays. But for you, as the simplest one, the most common one used, and the most easy, or the easiest one to communicate or to tell about or to classify distal radius fracture is the A1. So it is a forearm takes the number 2, radius takes the R, and as any other distal end bone, you have the A, which is the extra-articular, B, partial articular, and C, complete interarticular. So this is the easiest one if you want to memorize any of these. In addition to the classification, we have common named fractures for distal radius. The most commonly used and the oldest one is Colles fracture. But you, as an orthopedic surgeon, it's not accepted for you to say that I have a Colles fracture. But you can hear it from your colleagues. Smith one is the reverse one, where you have distal radius fracture with volar angulation. But here, for the volar shear fractures, you use the volar Barton fractures. And commonly you will hear as orthopedic surgeon that, okay, I have a volar Barton or I have a dorsal Barton. You can use these. For the dorsal shield, one, the volar aspect will be intact. The dorsal fracture dislocation or subluxation, it is the dorsal bottom. And if you come to the signs and symptoms of distal fractures, usually patients, they have pain, swelling, gross deformity. And as you said, you have to know if there is any open wounds communicating with the fracture site or not. And ecchymosis, and the typical for dorsal displaced fractures, we call it the dinner fork deformity. And you have to assess as part of your examination if the patient has numbness or have signs of acute carpal tunnel syndrome. Now we come to the important part, is the treatment. So the goal, as any other fracture, you have to maintain the patient's functional status, and you have to take the patient as a whole when you decide how to treat distal fractures. And the point or the problem in distal fracture is not like, let's say, a neck of femur. Most of your patients will treat them surgically because they can't get out of the bed, and your aim is mobilization. The story is different in the distal radius. You have to assist the patient as a whole and tailor your treatment accordingly. And as I said, there are multiple factors you have to consider when you are treating distal fracture. The most important one is the fracture pattern. Whether this is a comminuted one, non-displaced, intra-articular, extra-articular, displaced or non-displaced after reduction. The age. Definitely the first case was 30 years old and the second one 70. Your plan would be different. The functional status and the hand dominance. So an elderly patient with a non-dominant hand will tolerate, let's say, more deformity or more malreduction of a distal radius rather than an active 40 years old male patient right-handed with a right distal radius fracture. The comorbidities, if you plan to do surgery, this you have to take into consideration, and the patient expectations. And this is especially important, especially in young patients with comminuted fractures. You have to discuss with them that this is a bad injury and it will never go back to normal. So the patient and the doctor will have a real expectations. Now, as a rule, whenever you are faced with a distal radius fractures, if it is a displaced one, you take your decision after reduction, not before. But you have some hints that might give you a clue that this fracture is unstable and mostly will go for surgery. But as a rule, when you say a fracture, I'll take my decision after doing the reduction. So for all displaced fractures, most patients should undergo reduction DRA. وحكينا احنا most patients, because sometimes you are faced with a patient who is 90 years old with a dorsal angulated fracture, minimally one, and you don't need to reduce it because he's very elderly. So as we said, most patients should undergo reduction in DNR regardless of the analgesia that's used. Most commonly use hematoma block, but you can use intravenous or regional or even general anesthesia. It depends on the local policy. And the literature said that the least effective one is the local hematoma block, but no matter the anesthesia that you use, they don't affect the reduction. So reduction is a technical wise from the surgeon, but the let's say the least useful one or pain relieving one is the local hematoma block. Treatment in general, the options that you have as any fracture, you have operative and non-operative. The operative treatments, you have external fixation or internal fixation. And the internal fixation, you have the close reduction and wiring, polar plating, dorsal plating, and dorsal spine plating. That's why it's a wide topic to talk about, and you have many treatment options. The first one is the non-operative. It remains the most common one. Around 60 or 70% of distal radius fractures worldwide are treated conservatively. And recent studies have shown that the younger physicians اللي عمرهم تحت ال 40 سنة, mostly they will choose surgery easily because they are trained to see more distal radius fractures treated surgically. However, the senior surgeons or the older surgeons would choose more non-operative treatment. If we come to the close reduction, وصراحة يعني كثير موضوع مهم. Now even just 5 minutes before the lecture you must have noticed that on the on-call group there is a case of distal radius fractures be 73 years old male patient and the reduction was not that let's say efficient. ما بعرف شو اللي كان موجود بس as a point you should give your maximum effort to do the close reduction and usually it's done by traction and counter traction in our settings. You do traction in order to disimpact or to do ligamentastasis. Then you correct if it is a dorsal displaced fracture, you correct it by 3-point, let's say, reduction, palmar or volar pressure on the wrist. And somebody has to counteract you or you counteract yourself by doing a dorsal pressure on the distal forearm and you get the reduction. If this doesn't work, sometimes you exaggerate the deformity, then you do flexion of the wrist. And as a rule, there is all these fractures should be treated by below elbow cast. There is no rule for above elbow cast. And always remember to keep the metacarpophalangeal joints free. If the patient presents initially with a non-displaced fracture, the literature says that you can't treat it with a cast with a single follow-up. So if the patient presents with a non-displaced distal radius fracture, it is very unlikely to displace later. So you put a back slab or a cast and you review the patients once at 4 or 6 weeks to start range of motion. If you do a reduction and you see that the fracture is stable after reduction and acceptable, you follow it regularly at 3 weeks with x-rays, then at 6 weeks. And as we said, we take our decision after reduction. But once you have done the reduction, that you will have some, or even when you look at X-rays, as we made in the beginning of the lecture, you will have some clues or parameters or things that makes you alert that this fracture might be unstable. It might redisplace even if it is initially spaced, or it might benefit from early fixation. Like as we said, the loss of radial height and initial dorsal angulation of more than 20 degrees. This is the most important one, metaphyseal comminution, because it makes logic that if you don't have a cortical opposition, the fracture will collapse. Interarticular radiocarpal fractures, especially with more than 2 millimeters step, they are considered unstable. Associated ulnar fractures or ulnar head, these fractures are usually unstable, not the ulnar styloid, guys. And the age, over 60. In patients, as we said, in low demand patients, you might not do a reduction and you might just give them a back slab or a cast for 3 weeks or 4 weeks for pain control, then they start range of motion. Operative treatment. Now, the American Academy, in their latest clinical practice guideline, they can't recommend or vote with or against surgical treatment for distal radius fractures. But they said in very selected patients, they might benefit from surgical fixation. High our point. The second point is they can't recommend any, let's say, any specific method of operative fixation over others. These are the recent recommendations by American Academy. The first option of surgical treatment is the closed reduction. Closed reduction and percutaneous spinning. So you do reduction as you do the NE, then you put some K wires through the skin. It requires little equipment and minimally invasive. It usually reserved for the unstable extra-articular or minimally invasive articular distal radius fractures. So as a rule, mesh كل intra-articular fracture, you need to do surgery, or mesh كل intra-articular fracture, you need to do volar plating. And if you see here on your left side, this wire, next to it, there is an articular extension. So this is an articular fracture. They treated with K wires and they maintained or they gained a good reduction with acceptable parameters. طبعا هاي الفوتو من كتاب روكوود. Also, a large interarticular radial side fracture can be treated with K wires. So the literature says that there is no difference between the techniques. If you go from the radial side to the ulnar side, if you go from dorsal to voral, this doesn't matter, and the number of pins, but at least you have to use 2. But there's no difference between 2 or 3. At least 1.6 K wires should be used. The wires are left in place for 6 weeks with a cast. some centers they don't keep it proud of outside the skin. They bury the wires underneath the skin and they put a cast. Complications as any part of percutaneous fixation is pain tract infection and the superficial radial injury. So it is recommended when you do a radial surgery, when you try to put a wire, to open a slit incision and to spread the soft tissues down to the bone, then to put your wire. And by this, you maximize the chance of avoiding the superficial radial nerve injury. The second most common, or the second option of treating is the volar plate. It is introduced in around 2000s. It's a volar locking plate. It is used for the unstable extra-articular fractures, and especially for the volar shear fractures, the one that we said fracture subluxations or Barton fractures, and the complete intra-articular fractures. And as a plate, you should have enough bone in the distal segment, distal fracture, to have a purchase for the screws. If you don't have, there will be some volar limb fractures designed specially to go as distal as the distal piece of fracture, and this is the rim plate from Centis, and you see that this plate can go as distal as the volar rim of the fracture of the distal radius, and the screws they come almost 90 degrees to the plate to capture very distal segment. Few words about the approach. Most commonly, we use the modified Henry approach for the distal radius, or we call it trans FCR or the FCR. This is a cross section. This is the anterior, posterior, and on your right side, this is the radial side. So you open skin, subcutaneous tissues, you open the sheath of the FCR tendon, and you retract the tendon ulnarly. And by this, you go between the FCR tendon and the radial artery. This is the modified Henry approach. And you go through the floor of the FCR sheath, then you face the pointer quadrates, and after that, you face the distal radius. Now, a special view, when you try to place your distal radius plate, it's important to take this view. They call it sigmoid notch view. You try to take multiple views after reduction till you have superimposition of the volar aspect and the dorsal aspect of the sigmoid notch of the distal radius. By this, you can guarantee that this screw is not going to the distal radioulnar joint. We call it sigmoid notch view. And another problem or technical issue that you have to assess is the dorsal tangential view. You do wrist flexion and elbow flexion, and you get the X-rays tangential to the wrist. And this is specially designed review to assess the dorsal penetration of the screws of the dorsal cortex of the distal radius. And as you see here, if you follow the pointer, you point the distal radius, and all these screws are not penetrating the distal radius cortex. And a special care, the first one Muhammad mentioned, the volar lunate fragment. This is an important, which is the most ulnar and the most volar aspect of the distal radius. This piece has the strong short radiolunate ligament, and this by name, namely this connects the distal radius to the lunate, and this fracture has to be catched or fixed. Otherwise, if the dorsal ligaments are injured or there is a dorsal fracture, the whole wrist might subluxate. If you look for the left side here on the pointer, this is the lunate facet or the volar lunate facet, and you can notice that the lunate has followed this piece. The rest has subluxated volarly because this fracture was not addressed by this plate. As complications, most common complication is the soft tissue irritation, whether volary or dorsally. If it irritates the volar aspect of the distal radius, you might get a flexor pulsus longus. But overall, the EPL is the most common injured tendon, whether you treat it conservatively, surgically, dorsally, or volary. The EPL is the most common one, and usually it is injured by the prominent distal screws. The rule now for the dorsal plate is becoming less and less with the introduction of volar locked plate. It was common once, but now it's less common. It's usually kept for the dorsal sheared fractures and the die punch components. Dorsal sheared fractures, because the volar aspect would be intact, so there is there's no role of addressing that from the molar aspect. You have to go from dorsal. The second thing is, if you want to expose the distal radius articular surface, it is easier to do it from the dorsal side. So in die bunch component, you open a window from the dorsal aspect and you address it from the dorsal aspect. So as we said, this is a dorsal shear fracture. If you notice here on the right side CT that the volar aspect is intact, so there is no role to go from volar to address a dorsal one. So you go from the dorsal side and you apply your plate. And again, most common problem with these plates, because you don't have plenty of soft tissues there to cover the tendons. So most common complication is irritation of the extensor tendons, mainly the API. Another specific consideration in distal radius fractures, some people advocate the fixation each piece by itself, and they call it fragment specific fixation. In general, we tend to do distal radius volar plate to address all these things. But some people, some surgeons advocate that if you address each piece alone, you will get a better result. So if you got a cross-section CT of the distal radius, this would be the typical deformity, the difficult fragments, volar lunate, ulnar lunate, and radial stridor. So you have fragment specific fixation. They address the volar corner by a plate, the radial styloid by a plate, and the dorsal ulnar corner by a plate. And this is a schematic view of how it would appear. If you come now to the external fixator for this fractures, and as any other indication in any other fractures, if the patient has bad soft tissue injury that are not operable, you do an external fixator. Or the second one, which is important, that the fractures that are not amenable to RF. In extreme comminution, like in this case that you see, whatever you do, it's very difficult to collect or anatomically reduce the fracture. So your plan is just you can span it with external fixator. Complications and any other external device, pen site infection, superficial radon nerve injury, and stiffness and CRPS. And you have to focus on this. شباب لما نعمل external fixator, if you distract the joint excessively, the patient will have finger stiffness and chronic regional pain syndrome. So please keep it in your mind. You just gain your reduction and you don't do over distraction. And this is a case, and usually the external fixator is accompanied by percutaneous wiring to hold the fragments well. The external fixator itself, it does ligamentaxis, it restores the height, and you can do some percutaneous reduction by wires. Another way of spanning the distal radius is the dorsal spanning plate from the radial shaft to the metacarpals. It is an internal fixator rather than external fixator, and the difference between this and the distal radius, although they span the rest, this allows immediate weight bearing. So a patient with polytrauma, who has femur fracture and has a distal radius fracture, you can, and the patient, let's say, needs a walker to ambulate, you can do a dorsal spanning plate, and this will allow him to immediate weight bearing. Usually we reserve it, as we said, for community fractures, and we remove it after 3 months. And as any other dorsal intervention, the tendon irritation and stiffness are the most common complications. And this is an X-ray. You see, we do it percutaneously. You open proximally and distally, and you open on the middle just to elevate or to isolate the extensor pollicis longus, and you pass your plate. It is usually done with the third metacarpal and sometimes on the second metacarpal. It depends on the surgical preference. Now we come to some literature or updates. We finished the treatment options، طبعا هذول based على روكوود او الستاديز اللي موجودين فيه. البيركوتينس pinning versus external fixation, the most recent big two studies, they found there is no significant difference in radical outcome, complications on function. The second thing, percutaneous pinning or CRPP versus volar looking plate. Initially, at 9 or 12 weeks, within the 3 months, patients with volar plating are doing well, but at 1 year, there will be no difference. and هذا الشيء الوحيد اللي حكوا عنه بالامريكان اكاديمي انه some selected patients might benefit from early fixation with locked plate like these patients, especially young, they need to go back to work. They can't be spent for 6 weeks. They might benefit from volar locked plating, but the literature in general, it says that there is no difference between close reduction wires and the distal volar plate. Again, external fixation and volar locked plate. This is a big trial, randomized for RCT, and 1 year they found same function between two groups where complication rates are similar. This is the important thing. We have just said that some surgeons advocate that if you fix each fragment alone, you will get better results. But the literature has found that there is no difference in outcomes, and moreover, the fracture specific fixation or fragment specific fixation gives higher rate of complications, especially the median nerve irritation or neuropraxia, because they go not the FCR approach, they go ulnar sided approach to fix the volar lunate segment. Another update is there's a growing evidence that treating distal radius fractures in above 60 years old patients have the same results, regardless you do surgery or you do it conservatively. And as a scheme, if you go just have a look on this algorithm, you have a distal radius fracture, it's either non-displaced or displaced. If it is displaced, you treat it for a cast 6 weeks, one visit, and that's it. If it is displaced, you do a reduction, and then you assess. If it is unstable, even after reduction, you might consider fixation. If it is stable, after reduction, you follow it weekly with X-rays for 3 weeks. If it is stable, you continue 3 weeks. If it redisplays again, you might consider surgical fixation. Now, just a few comments on a few things. As we said, the extensor pollicis longus is the most commonly ruptured tendon, regardless if it is conservative, surgical, and if it is surgical, voral or dorsal, the most common injured one is the EPL, and usually treatment is transfer of the EIP to the EPL. Flexor tendon injury can happen from volar plating and can be managed by removing the plate with primary repair if it is acute or recent or tendon grafts. Malunion usually happens with elderly patients who are treated conservatively, and you should treat the patient rest and symptoms rather than the appearance of X-rays. And the most commonly used treatment if the patient is symptomatic is distal radius osteotomy plus minus ulnar osteotomy. And the last topic that we want to talk about is the complex regional pain syndrome. بال 2010 American Academy Clinical Practice Guidelines, they had a moderate recommendation for the use of vitamin C. However, the recent meta-analysis failed to show that vitamin C demonstrates a significant benefit or prevention from the chronic regional pain syndrome. Any questions? الله يعطيك العافية.
دكتور محمد الله يعطيك العافية، كيفك؟
هلا سيدي.
أول شيء شكرا لك عشان وضحت موضوع الراديولوجي ووضحت لنا قديش يعني عندنا صور بجوز ما لها معنى بتقييم المريض. مظبوط، يعني بصراحة هذا بنشوفه كثير. طبعا الحق بجوز علينا احنا، لأنه احنا بنتوقع انه يعني الراديوغرافر هذا اللي او التكنيشن بيعرف، هو ما بيعرف، فلازم ندله ولازم احنا نكون قاريين. فاللي بصير الجونيور ما بيعرف يقيم، تيجي الصورة بقبلها اللي سينيور، بقبلها السبيشالست، وبالتالي بتوصل تكون مينينجلس. فيعني هاي كمان، واحنا طبعا حاولنا ندخلها حتى في اسئله الامتحانات، يعني يكونوا الناس اوير ويقروا عنها ويفهموها، يعني حتى يعني يصير في كوميونيكيشن. فبنتوجه الزملاء المقيمين ينتبهوا لهذا الموضوع، لا الصور تكون ادكويت وتعطينا بصراحه مينينج، يعني بتساعدنا تو جايد اور مانجمنت. فشكرا لك تو بوينت هذا الموضوع في بدايه المحاضره. في شغله ثانيه حكيتها بصراحه شويه، يعني اللي هو موضوع انه اسم كوليس فراكتشر، بس تعرف احنا هذا سؤال كلاسيكال، ويعني تقريبا العظام او اي تخصص يبنى على يعني على الهيستوري، على الكلاسيكس. فهو كوليس فراكتشر مقبول تستعمله اذا انت كنت تعني الكولز as defined by college. هلا هو
أها.
مش مقبول تستعمله انك تدل على كل distal radius fracture with distal angulation، هذا كولز مش مقبول كجراح عظام definitely. but if you say college fracture، فاللي قدامك لازم يعرف شو معنات كولز. يعني عم بقصد الدكتور مثلا extra articular with dorsal angulation with shortening with يعني اللي هو شو definition of college as college. بس هو مش مقبول زي ما تفضلت نستعمله to describe every distal radius fracture with dorsal angulation. بس يعني هو دائما يعني هاي الاشياء بنكون احنا مور سبيسيفيك فيها، يعني ما بعرفش اذا انت، انا لاحظت حكيت انه مش مقبول نستعمله، فبجوز هو مقبول نستعمله فقط اذا بنعني الشيء الواضح اللي حكى عنه كولز، لانه كولز قبل كولز كان كل اسمه ديستال راديوس ترى. فاحنا
يس.
وكانه بعد هيك رجعنا بدنا نلغي كولز وسميث وبارتون وبدنا نرجع لديستال راديوس مع كذا ومع كذا. ما هو قبل هيك كانت اصلا هيك القصه، فاجوا
يس.
الجماعه يعني اعطوا اسماء والقصد منها تسهل اصلا كمان communication. but as you mentioned it's not accepted to honestly يعني name every distal radius fracture مثلا ككولز. هاي هي الفكره يعني. اما اذا انت حكيت كولز فانت بتعنيه فبتعني واحد اثنين ثلاثه اربعه، فهي كوميتل كنيم.
يس.
وهو ايضا زي ما انت عارف يستعمل كلاسيكال كانترودكشن مثلا، يعني كويستشنز للجماعه بدهم يجوا عندنا على العظام كالفيرست يير ستودنتس. فهو موجود اصلا في الاف ار سي اس اكزامز وهي الشغلات موجودين، هذا يعني موجود كمصطلح يعني.
يس.
فبس يعني تنويه. وبالعكس شكرا لك على المحاضره رائعه جدا، الله يعطيك العافيه
الله
كثير،
يعافيك.
يعني سمبليفايد الايشيو، يو كويند الاشياء المهمه اللي بتهمنا يعني. واثرت طبعا اكيد كمان الحماس تبع خلينا نحكي الحضور باسئلتك في بدايه الليكتشر. فثانك يو فيري ماتش، ثانك يو. وشكرا للزملاء اللي شاركوا كمان المقيمين في البدايه وشاركوا وتشجعوا، وبصراحه يعني وتحملوا اي شيء ممكن يصير، لانهم هم يعني قدموا اللي عندهم ما شاء الله عليهم، يعني عندهم معلومات ممتازه، الله يعطيهم العافيه.
شكرا لك سيدي. بس احنا بس if we go back to the first case that we showed, just to يعني let's say to highlight what we have said. Now, this is a 30 years old, and we said that this is different from the 70 years old. And we said that you have some parameters that might give you a clue that this fracture is inherently unstable. Even if it is stable surgically, stable after reduction, you might consider early fixation. فهذا عمره 30 سنة، عنده volar comminution، وعنده dorsal comminution، وعنده ulnar styloid، وعنده initial angulation more than 20 degrees. وin addition to that he is right-handed وعمره 30 سنة. فالديسيجن was to do open reduction internal fixation. وهاي العفو منكم بس ثواني. طبعا هذول ريل كيسز من الاون انكول ادمشنز، يعني انا طلتهم. وهاي الفولو اب على 4 months and he has good and as you see that the parameters are restored on both AP and lateral and he has good clinical outcome. والحج اللي حكينا معها هسه what I want to point scientifically ال gender doesn't matter whether to go for surgery or conservative. بس انا بالعمدن كونه we have to be a bit more practical. يعني احنا بس بالمجتمع تبعنا عمرها 70 سنة وسبيشالي حكيت فيميل مع انه ما بصير احكي. بس just to give you a clue, a non-dominant hand that you have a low threshold for treating this conservatively. ونعملها reduction وكان almost acceptable على عمر 70 سنة. وحكينا انه في growing evidence انه بالelderly patients بالlow demands الاوتكم is the same. والله يعطيكم العافية وكل عام وانتم بخير.
يعطيك العافية دكتور محمد، محاضرة رائعة. يعطيك العافية دكتور مثنى سيدي على المتابعة، ومبارك دائما سيدي. دكتور محمد محاضرة رائعة، شملت البيسكس وشملت الأبديتس
شكرا ناصر.
كما توقعنا منك. كل الأبديتس اللي كنا نتوقع نسمعها سمعناها منك، يعطيك العافية. شباب في عندكم أي سؤال؟
الله يعافيك يا ناصر.
طيب احنا قبل ما ننهي بنهاية محاضرتنا اليوم وصلنا لنهاية التراما موديول. خلال الشهرين الماضيات أخذنا مجموعة محاضرات ومجموعة كيس ديسكشنز. وزي ما تعودتوا في نهاية كل موديول في عندنا موك إكزام عشان نشوف كيف مدى استفادتكم من المادة اللي طرحناها. الأربعاء بعد الجاي، يعني الأربعاء بعد العيد إن شاء الله راح نبلش بالبيدياتريكس موديول، محاضرة عن بريكال بلكسس انجريز. في نهاية المحاضرة راح نعمل موك إكزام عن التراuma موديول. الامتحان راح يكون عن المحاضرات المحتوى المحاضرات اللي أخذناها في هذه الدورة من محاضرات وكيس ديسكشنز، زائد راح نتطرق لمواضيع أخذناها في الدورات الماضية كمان. كل المواضيع اللي أخذناها في الدورات الماضية موجودة على التطبيق وعلى قناة اليوتيوب، بإمكانكم ترجعوا لها وتراجعوا لها، تراجعوا مواضيعها خلال الأسبوعين هذول الجايات إن شاء الله، عشان تكونوا جاهزين للموك إكزام. وللتنبيه والتأكيد، الموك إكزام والكيس ديسكشنز وحضور المحاضرات عليه جزء من علامة التقييم السنوي اللي بيتم قبل كل امتحان سنوي. نتمنى لكم التوفيق والنجاح دائما. وأي ملاحظة سيدة بركان جاهزين؟
الله يعطيك العافيه دكتور ناصر، ما شاء الله عليك،
الله
وشكرا.
يعافيك.
الله يعطيك العافيه.
الله يعافيك باشا. يعطيكم العافية جميعا. تقبل الله طاعتكم وكل عام وأنتم بألف خير.
بخير جميعا إن شاء الله.